Hi, I'm Bree Watson, and I'm the marketing manager at Warwick Forest, sitting here in our lovely library in our commons. And I'd like to tell you today about Dr. Elsie Achieng. Dr. Achieng earned her medical degree in 2013 from the Morehouse School of Medicine in Atlanta. She subsequently completed a neurology residency at The Ohio State University, remaining there to complete a sleep medicine fellowship. She completed an additional fellowship in clinical neurophysiology with a focus on EEG and epilepsy at the University of Maryland Medical Center. Dr. Achieng is board certified by the American Board of Psychiatry and Neurology. Dr. Achieng's longtime fascination with the function of the nervous system inspired her to pursue a career as a neurologist. She is passionate about diagnosing and managing neurological conditions with particular interest in sleep disorders and epilepsy. Dr. Achieng works hard to help her patients, caring for them with the same compassion and respect that she would extend to her own family. Originally from Nairobi, Kenya, Dr. Achieng enjoys living near the beach in Hampton Roads with her husband. Her favorite pastimes include traveling, cooking, and painting.
So today, I'll be talking about seizures, just going over an overview of what seizures are and learning what we can do if we encountered with somebody who has a seizure. So just starting off with lecture objectives. We'll define seizures, identify the different types of seizures, understand different causes of seizures, learn about seizure mimics, learn how to help someone having a seizure, identify when to call emergency medical services after witnessing a seizure. And if anybody has any question through the slides, please feel free to ask away. All right, sorry. So when we talk about seizure, we talk about either a change in behavior, movement, or any level of consciousness of a person. And this stems from a sudden burst of abnormal electrical activity in the brain. We think of the seizures that happens in phases, and not everybody has this stepwise progression of their seizures. Some people can just have like a warning sign that happens before the seizure. And this could be a rising epigastric discomfort, having a deja vu sensation, and a strange feeling. There's also what happens during the actual seizure, we call this the ictal phase, where you can have staring, confusion. Some people have automatic behavior where they can reach out as if they're touching the blanket, or whole body stiffness. And then postictal phase is what happens after this seizure. And I guess somebody has some questions about the topic. Thank you. So there are different causes of seizures. So we think of seizures as either, we used to think of them as provoked, but this we call it an acute symptomatic seizure. This is a seizure that happens within around the same time or within 24 hours of having these abnormal either derangements with different metabolic systems in the body, or exposure to drugs, either intoxication or withdrawal, or exposure to extreme heat. Most commonly, the first thing we check when somebody has a seizure is making sure that their blood glucose is normal. Sometimes somebody can have abnormal kidney or liver function, and they can potentially have a seizure from that. Withdrawal from alcohol is a common cause of seizures. And then, if somebody's using illicit substances like cocaine, if it's too much that they can have a seizure. So this does not mean that they have a tendency to have seizures or recurrent seizures. It's just they're exposed to a situation that increases the chance of seizure. And then at the bottom here, these are unprovoked seizures. So there are certain things that happens to the brain, either having a head trauma, a stroke, or just development in the brain structure itself that can make someone prone to having seizures. If somebody has had an infection in the past, like meningitis or encephalitis, and then certain autoimmune conditions where you have certain antibodies attacking specific receptors in the nervous system that can make somebody have seizures, and we consider that as remote symptomatic seizures. And then there's a long list of different epilepsy syndromes with genetic component. Tend to see those in younger population. And sometimes we don't have a clear cause, so that's called idiopathic seizures. As we get older, the most common cause of seizures is if somebody's already on seizure medication and they missed a dose. That's the most common cause. And then going back to these structural reasons, stroke, tumor. So if somebody has Alzheimer's, dementia. Okay. And then, so we define what seizures are. So epilepsy is a disorder where someone has 2 or more recurrent unprovoked seizures. And this is just a brief overview of the persons affected through the world in the United States. And currently the data we have is there are 3 million people in the US with epilepsy, and about 150,000 new cases in the United States yearly. Okay. So we think of seizures as based on where they're coming from in the brain. They either come from one spot in the brain, we call those focal seizures. And when somebody has these type of seizures, they can be aware of the surroundings. And some of these seizures, they're not aware of the surroundings. Previous terms they used to call these are simple partial seizures or complex partial seizures. I think people use the word petit mal to interchangeably mean these type of seizures, but what that means is actually a generalized seizure where the electrical activity is coming from the entire brain, and it can cause different physical manifestation. Most commonly we see is the generalized tonic-clonic seizures, which are common term people use is grand mal seizures, but we don't use that anymore. We just use a generalized tonic-clonic. It could be generalized atonic, or absence seizure is what used to be called petit mal, and that typically involves staring, and then myoclonic seizures. So when we, again, just walking through what seizures are and how we picture the brain in our mind when we're hearing about a seizure or seeing a seizure. So this is just a picture of the normal electrical activity. It's quite, pretty quiet there. And then when somebody's having a partial seizure, this electrical activity becomes too much and takes off from one spot in the brain. So this is just a snapshot of what the electrical activity looks like for a partial seizure. And then generalized seizure, we means both parts of the brain is firing at the same time. So you see the electrical activity takes off throughout both hemispheres. So for epilepsy, again, just the condition of having recurrent unprovoked seizures, risk factors for having epilepsy, kind of going into what we talked about, the causes earlier, include family history of epilepsy, especially in those genetic type of epilepsies. Some people had seizures when they were younger during a fever, and depending on how long that fever lasted and what neurological deficits they had, that can make them prone to have seizure later in life. having head trauma where you lose consciousness for hours and hours. Again, talking about the different brain lesions like stroke, tumors, and infection. So persons with epilepsy have certain triggers to their seizures, and we just know that when they're exposed to these situations, they have a lower threshold to have the seizure. So most commonly is somebody would be exposed to bright flashing lights if they're not sleeping well enough. Sleep deprivation. For most adults, sleeping less than 7 hours a night is not enough. But some people are short sleepers, some people are long sleepers. So it just depends on what the good hours of sleep is for the person. Also stress, and then dehydration. We just see that certain people, their seizures are very prone to become more often when they're exposed to these different situations. So I'm just going to pause here for a second and just review what the brain looks like and the areas of the brain that we think about when we hear about a seizure, think about a seizure. Again, just trying to differentiate between that focal and generalized. So this is the picture of the brain, and you can picture this is a person standing on their side facing the front, and this is their left side. And so the front part of here, we call this the frontal lobe. Down here, this is the temporal lobe, and then parietal lobe and occipital lobe. So we'll just walk through the different parts of the brain, what they normally do, and then what we expect seizures from each part to look like, okay? So the temporal lobe, this is the area of the brain that typically is involved in, our memory functions, regulating emotions, hearing, auditory processing, and then how we process what we see and how we understand language. So seizures from this part of the brain are the most common focal seizures, and they typically present with somebody staring, or they're not responding, or somebody will say they just lost track of time. Some people have that automatic behavior. They look like they're making chewing movements with their mouth. They look like they're trying to pick at something that's not quite there, or they just have repetitive movements. It could be the rocking. And then another common feeling that they can have is just feeling this weird, strange rising sensation in their stomach. And then when we say deja vu, they can feel like the situation they were in, it's very familiar. And some people can also have this abnormal taste or smelling sensation. There's weird sensations that they can have with the temporal lobe seizures. And then the frontal lobe, so that's the area that is, has involved with movement. So each time you're trying to move your arms, your legs, that's the signal is coming from the frontal lobe. There's also language production there, mainly how we produce speech each time we speak. More so the expressive language, not so much how we understand. And then, complex things like planning movement and executing movement, and then personality. So seizures from this area, again, of the focal seizures, this is the second most common, and they can be very brief, and they tend to occur out of sleep. So sleep and seizures go really hand in hand. There are certain, sleep happens in stages where during arousal, then you go into lighter stages of sleep. We call that stage 1, 2, and then deeper stages of sleep, 3, and then REM sleep. With seizures, we tend to see them occur more in the stage 2 sleep. It's a huge area of research. We don't know the exact mechanism why that happens, but we tend to see them more out of sleep. And especially these frontal lobe seizures, they tend to occur a lot at night, and they can look pretty violent, where the person could be screaming, flailing their arms and legs around, looks like they're riding a bicycle or they're running, and then they can be quite aggressive. There's certain seizures coming from this part of the brain that has a genetic component, and we call that as sleep-related hypermotor seizures. We used to call it autosomal dominant nocturnal frontal lobe epilepsy. Over time, we're learning that the brain is connected, and sometimes it doesn't quite start at the frontal lobe. It could start somewhere else and spread to the frontal lobe. And so we just now change the term to sleep-related hypermotor seizure because they have a lot of movement, can be violent. But the key to these seizures is they're very brief and they can last seconds. Okay. So the parietal lobe, that's where our sensation is. Every time we feel the touch, temperature, and pain, this is where it's being processed. It's also involved in visual processing, and just knowing our orientation in relation to the space. As you can see up here, this picture is very small, but the parietal lobe is quite connected to the occipital lobe there. Seizures from this area are quite rare, but we can, if somebody just keeps having recurrent brief episodes where they have numbness and tingling and burning pain on one side of the body, rarely hear hallucinations from this, but it's mainly sensory seizures. We think of the parietal lobe. And then finally, the occipital lobe, that's where the vision processing center in the brain. And again, seizures from this area are still also rare. But when we hear somebody's having recurrent episode of seeing bright flashing lights, visual hallucination, or just constant eye blinking, eye movement, they come and go. It's, we call it localization in neurology. We think of the back part of the brain. Okay. And this is just a busy slide, but it's basically a summary of what I just went through with the different parts of the brain that we think about seizures are coming from, and then the different manifestations of the seizures. So if you think about that picture with that electrical activity taking off, it becomes an emergency when it's prolonged. So we know that seizures lasting more than 5 minutes, or if somebody has repeated seizures, that can lead to damage to the brain, and we treat that with the utmost emergency and have a protocol in place to respond to that. There's a huge area of research on how, just the effect of epilepsy on the individual overall. And the major area of research is seeing how this can contribute to cognitive impairment. The different factors that can contribute to this, such as, having had a prolonged or frequent seizures, certain medication certainly have cognitive side effects. One is called Topamax or topiramate. And then we see a lot of psychiatric conditions in persons with epilepsy, especially anxiety and depression. And it's not so much the direct result of the brain injury or brain cell damage from the seizure itself, but just when somebody has a seizure, they have to deal with the psychosocial consequences, especially, losing independence and having to wait a certain amount of time before they could drive. So we tend to see, depression and anxiety go hand in hand with this. And when that's going on, that can contribute to certain short-term memory, difficulty concentration. And then with the temporal lobe seizures, we know that with those over time, with imaging, certain MRI findings, we see there's a loss of brain cells in that part of the temporal lobe called the hippocampus. So not everybody that moves around, especially out of sleep or any episode of staring or confusion means that they have a seizure. So there are certain things that we think about when we're evaluating somebody who has a seizure. Sometimes, somebody could just have a syncopal episode where they pass out. They typically come, typical symptoms: feeling calm, sweaty, clammy. They rapidly return to their usual self, and they can remember details before and after. You can have like abnormal heart rhythm, such as low heart rate with the bradycardia. And then going back to our first slide over there, as far as the causes of seizures, having low blood glucose that can lower the threshold of having a seizure. Some people with migraines can have phenomena that mimic seizure, especially those with migraine aura, and you see bright flashing lights. Kind of going back to that slide where the occipital lobe, so that can kind of be confusing picture. And then sleep disorders, those that involve movements out of sleep, we collectively call them parasomnias, but some people have REM sleep behavior disorder or night terrors, nightmares, just certain things we have to distinguish. And sometimes it's hard to distinguish by just hearing the story or looking at the person. We would need to have EEG monitoring with electrodes in the scalp to capture the episodes and see the brain activity as it's happening. And that helps us distinguish, is it a sleep disorder or is it a seizure? And then certainly not all shaking means that somebody has a seizure. So there's certain movement disorders that can look like seizures, especially if somebody has tremors, whether it's from essential tremor or Parkinson's disease. And then a commonly encountered condition that we see is called psychogenic non-epileptic seizures. Popular term that people use used to be pseudo seizures, but we try to stay away from that because it's a negative connotation, and it can give the impression that the person is faking whatever they're experiencing. So we just call them psychogenic non-epileptic events because they either, whether it's the staring, the whole body shaking, it looks like an epileptic seizure, but when we monitor the brain, we do not see the electricity taking off with the abnormal electrical activity. So certain clues to that include, these episodes last very long. It could be up to 20 minutes. Up to 20 minutes, their eyes are closed during the episodes. With generalized seizures, typically we see somebody's eyes open and rolled up. They can have very violent movements, including pelvic thrusting. Somebody with this type of event, they can have a detailed recollection from the beginning to the end and walk you through every single movement that they're doing. And then again, being aware of their surrounding. One thing is not specific for it, but one clue is we also pay attention to, if they had a biting of their tongue, is it on the side or on the tip of the tongue? But this is something that can be quite confusing. I wouldn't expect anybody to try to make the distinction in your own. So we typically, we as a neurologist, we know what to look for and how to evaluate it. And it's usually a diagnosis of exclusion after we've gone through a thorough evaluation of the person. So what do we do when somebody's having a seizure? And I'll just pause here for a second if there's any questions pertaining to what we've talked about so far as what seizures are, the different causes. Okay, so if there's no other question, all right, so if you see somebody having a seizure, the first thing is just to stay calm. And most of the time, they end up going to the hospital. You'll be asked how long did it last? And the key is to also stay safe. If there's any nearby objects that could be harmful to the person, just move them aside. And then move the person to their side if they're not awake, alert, and talking to you. The main thing is just loosen tight clothing around the neck. If they're on the floor and there's something soft and small, like a soft pillow, you can put it underneath the head, but do not put anything in the mouth. I know some people used to put like spoons and all kinds of sorts of objects in the mouth to prevent the tongue biting, but we highly recommend that do not do that. And then when to call 911, of course, if you've never experienced this before and you're in doubt and it's the first time you're experiencing it, feel free to call. It's always better to be safe than sorry. But if you have somebody with a known seizure and they have medications on board and you're quite comfortable, you know, things that need to be evaluated if this is a first-time seizure. Somebody had a seizure, but they keep having them, so repeated seizures. They do not return to their usual state after the seizure. They have difficulty breathing. If there's any injury, the person is pregnant or sick. If the seizure occurred in water, and then going back to what we talked about, a seizure, prolonged seizure is a medical emergency because it can lead to brain damage. So a seizure lasting longer than 5 minutes then needs an emergent evaluation. Okay. And then again, do not restrain and do not put anything in the mouth. This is just a brief slide of certain seizure medications that you may encounter or see somebody having. And again, we just think of the medications when we pick them based on the type of seizure and then what other medical conditions somebody has and you know, side effects. So if you think about, you know, focal versus generalized seizure, so this list here, when I say broad spectrum, I think of these medications when somebody has both focal and generalized seizures. Some of those focal seizures can spread to the rest of the brain and become generalized. So these are good options for those as well. And then if they're not responding and they're still having focal seizures, then, you know, we pick one of these medications in this list, and the ones that are highlighted are the ones that are commonly used. These two, oxcarbazepine and lacosamide, are fairly new, but most commonly used, you know, this levetiracetam is also called Keppra. And then valproate is Depakote. Phenytoin has been on the market for quite some time, so that's the deadline 10. And then, does anybody have any questions so far? So if there's no other questions, I just wanted to pause here. A lot of this information can be found on the Epilepsy Foundation website, which is listed on here. And then I just thought it'd be a great topic to talk about seizures and at least go over what they are, how we think about them. In this month of November, because this month is Epilepsy Awareness Month. So, you know, just go to the website and spread the word about epilepsy, and there's many treatment options for it. Okay. Does anybody have any questions? All right. Okay. Mackenzie, I guess if there's no other questions, that should be it. Thank you.
I'm not seeing any other
Okay.
questions here in the chat. Looks like just compliments.
Yeah, well, thank you.
Yes.
Well, I just
thank
figured
you.
it's Epilepsy Awareness Month. We can talk about it.
Yeah, no, it's
So
definitely.
I apologize for the person who wanted a sleep lecture. I'd be happy to do one some
Okay,
other
well,
time.
I will let Amy Duncan know that, and hopefully that's something we could coordinate for the future.
Sure.
All right, awesome. Well, thank you so much for your time with us today. We really appreciate you taking the time out of your day, and have a good weekend.
Thank you. You do as well. Thank you so much.
Thank you.
All right.